Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from SK Life Science, Inc. This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
Thank you for joining us today. We're going to discuss maximizing therapeutic efficacy prior to epilepsy surgery. Considerations for the selection of anti-seizure medications. My name is Dr. Danielle Becker, and I'll be your moderator. I'm an associate professor of neurology and the division director of epilepsy at The Ohio State University Wexner Medical Center in Columbus, Ohio. With me today are my esteemed colleagues and faculty, Dr. Gregory Krause, professor of neurology in the Department of Neurology at Johns Hopkins University School of Medicine, and Dr. Jacob Pellinen, an associate professor in the Department of Neurology at the University of Colorado School of Medicine. Our learning objectives are going to talk about increasing knowledge regarding strategies to optimize seizure control in people with epilepsy. We want you to leave having a greater competence related to the personalized selection of anti-seizure medications to improve seizure control in our patients who may otherwise be candidates for epilepsy surgery. We know that epilepsy is associated with numerous consequences, regardless of how many seizures someone's having. We know that they can be associated with emotional and social difficulties, limitations in employment, in education, in the ability for someone to drive, and losing their independence. We know that there could be costs to the patients and the healthcare system. And we also worry about injury, trauma, sudden unexpected death in epilepsy, and also status epilepticus. But we also know that even having one seizure per year or one seizure in the past 5 years can still have an impact on our patients, with 3 times more likely experience of poor health outcomes, a 2 times more likely experience of stigma, 6 times more likely to have depression, 4 times more likely to have overall life limitations, 3 times more likely to have employment limitations, 4.5 times more likely to be prevented from driving, more likely to have limitations in education. We also know that the more medications someone's on leads to an increased drug load, and that impacts our patients. Drug load is not only the amount of drugs someone is on, but also the doses of those medications. And we know that when they have an increased drug load, they have worsened cognition. We know that this polypharmacy can add to the burden of anti-seizure medication toxicity with increased risk of adverse events, of lower quality of life, of non-compliance, and also higher costs to the patients and also the healthcare system. And studies have shown that reducing anti-seizure medication drug load is possible without compromising efficacy, with our primary goal being seizure freedom and improvement in quality of life. Now we're going to focus on the primary goals of epilepsy therapy, and I'm going to pass it on to Dr. Kress.
Hi. As Dr. Becker said, our goal with our patients is to become seizure-free. Now, the success rate with anti-seizure therapies is about 60%, where patients achieve full seizure control using anti-seizure medicines. The challenges of trying to control seizures, though, are that many patients experience side effects, adverse events of medications, which limit their therapy and their therapeutic benefits. Some patients also, at least a third, have very refractory seizures, which persist despite common treatments. Our additional goal is to control seizures and also to minimize side effects and comorbidities. Stigma is common associated with seizures, particularly with uncontrolled seizures. Now, there's a lot of changes in treatments that are available over the past dozen years or so. And as you can see, there's been a steady development of new anti seizure medications over the past century. But in the last 20 years in particular, there's been a big crop of new treatments that offer a lot of new benefits for patients. This means that we all have to learn to adapt these treatments and select the best treatment for our individual patients and learn how to minimize comorbidities, side effects, and optimize therapy using these drugs. Currently, we have kind of a shelf that's developed where many patients do not develop seizure freedom on standard treatments. And this has been the case now for about 20 years. Recently, though, as these various audits that have been done have shown, there's been kind of a limit where about a third of patients do not achieve seizure freedom. I must say, though, since 2012, we have additional new treatments which offer several benefits for some patients. In particular, probably 15% of patients are drug resistant because they're not tolerating their drugs. So we have new options of treatments that we can manipulate and avoid side effects and optimize treatment for patients and often allow them to have their seizures controlled. So here's seizure freedom outcomes in phase 3 trials with some newer drugs. You can see several of them don't, in highly drug resistant patients, don't offer high frequency of seizure freedom. Many of these drugs often also provide benefit for certain niches of patients. So, for example, brivaracetam has been shown to be effective for generalized epilepsy, just not for focal seizures. Carbazine is a very well tolerated drug that's been shown to be beneficial for focal onset seizures and doesn't treat perhaps some other seizure types. Cenobamate's a newer drug that you can see offers pretty high rates of seizure freedom in drug resistant patients. So it kind of stands out in terms of that feature. So when we encounter a patient with treatment-resistant epilepsy, we want to profile what their problems are. What type of seizures do they have? Do they need a drug that's better tolerated than previous drugs that they've tried? Are we trying to avoid drug interactions, or are there special needs for them in terms of their demographics?
All right, and I think it might be a good time to introduce what drug resistance means or how it's defined. And the official definition from the ILAE is that this is a failure of two adequate trials of two tolerated and appropriately chosen anti-seizure meds. Uh, the two well tolerated and appropriately chosen medications may just be the tip of the iceberg when it comes to possibilities. And because epilepsy is a progressive disease and people accumulate damage over time, it's important to optimize meds as early as possible to prevent that from happening over time. Um, Ongoing seizures, of course, lead to higher healthcare costs, can lower quality of life over time. And when newer drugs come out that show benefit in different populations, including drug-resistant populations, that's the time to try new treatments and continue to optimize aggressively. And so, how do you pick the right intervention at the right time? Well, it's very important to individualize approaches to treatment and to balance side effects or tolerability and other factors that can be very patient specific, such as affordability, how easy the medications may be to titrate, what the dosing frequency is, and what other comorbidities patients have, including medications they're already on, and pre existing health conditions such as potentially the presence of depression, cognitive cognitive comorbidities, as well as how old they are and whether or not they're potentially of childbearing age, and whether or not there are any surgical options that could benefit them.
Thank you very much, Dr. Krause and Dr. Pellenin. Now we're going to go through some cases to help highlight some of the takeaway messages we want to make sure that you gather today. So we're starting with my first case. I'm going to talk to you about a 34-year-old woman. She's a marketing executive and she's married. Her first seizure was at age 31, and she had no family history of epilepsy. When she came to me, she had a 6-month-old at home as well as a 3-year-old at home. She was worried about her job, her ability to care for her children, her ability to drive, and what seizures would mean to her life. When she first started having seizures, she was having 3 per day. She was then placed on levetiracetam, which reduced to 2 to 3 per week, but she still was having seizures that was impairing her functioning. Her triggers that she spoke about were stress and sleep deprivation. When I first met her, she was on levetiracetam, 1,000 milligrams twice a day, and had actually not tried anything else. She had comorbidities of anxiety and past medical history of asthma and postpartum depression. Her initial EEGs that she had in 2023 showed possible sharp changes over the left temporal region. An artifact was noted, so the EEG was originally called normal. However, out of concern, they then repeated an ambulatory EEG, a 96-hour ambulatory EEG that showed interictal discharges over the left temporal region. There then were multiple seizures that were captured that started over the left frontotemporal region and that evolved and spread eventually to the right frontotemporal region as well. She also had an MRI that was normal. So she had multiple different types of seizures. She had auras, or focal aware seizures. She explained that sometimes she would have a feeling if something bad was going to happen, or dread, or a metallic taste in her mouth, and these could occur multiple times a day. Often they remained focal aware, but other times they may progress to focal impaired awareness or focal impaired consciousness. These seizures, sometimes after the deja vu or dread, would start where she couldn't talk and couldn't respond for 1 to 2 minutes. As mentioned previously, these seizures would be 3 times a day prior to levetiracetam, and then after levetiracetam was started, reduced to 2 to 3 times a day. We decided to start cenobamate. So when I titrate cenobamate, I often go to 100 first and see how the patients are doing, especially if they're on other medications. When I titrated her to cenobamate 100 milligrams daily at bedtime, she went from 2 to 3 seizures per week to only 3 seizures over 6 months, and 2 of those 3 seizures were provoked in extreme stress conditions. I then increased the cenobamate to 200 milligrams daily at bedtime, and she achieved and maintained seizure freedom. I also had in mind that ideally, if the cenobamate offered better seizure control, then we could reduce the levetiracetam since we knew she had comorbid mood issues and anxiety. The cenobamate was increased to 200 daily at bedtime, and once she achieved seizure freedom, I was able to switch the levetiracetam to extended release and reduce it to 1,000 milligrams at bedtime. This was helpful. It helped her lower her drug load. It helped her lower her anxiety, and ultimately it gave her better seizure control to the point that she felt confident in going to get bariatric surgery. It also continued to help her excel in her role in her job and also at home with better mood and quality of life. Now, I'd mentioned that she had multiple different seizure types, so I do want to highlight that in clinical trial data with cenobamate, looking at 28-day seizure frequency, you can see that cenobamate had efficacy in both focal aware motor seizures. This is important to note because this did drive my decision also when she explained that she had focal aware seizures. You also can see efficacy with focal impaired awareness seizures or altered awareness. And lastly, looking at focal to bilateral tonic-clonic seizures, you can see the efficacy based on dosing. And you can see at an average cenobamate dose of 200 milligrams daily at bedtime. So in summary, in patients who continue to have seizures, we know that this impacts their lives. We know that it can have changes on their emotional functioning, on their social challenges. It can affect and cause limitations in education, employment, and daily activities. It can reduce their quality of life. It can increase the risk of sudden unexpected death in epilepsy. And we know that they also have consequences of cognition and inability to necessarily function at their highest capacity with increased drug load. And these are the takeaway messages that drove my decision to start Snowmate as second line and potentially to get her to monotherapy in the future. With that, I'm going to pass the next case over to Dr. Kraus.
Hi. One remarkable thing is when patients are treated with anti-seizure medications, it turns out often that actually quality of life is more determined by drug side effects than by seizure recurrence. And you see this in this study that was done in England. And so this is called the SANAD-2 study of focal epilepsy. And what they did is they randomized 900 patients with newly diagnosed focal seizures to three standard therapies: lamotrigine, levetiracetam, and zonisamide. And this is the retention curve over several years. And what you can see is actually lamotrigine excelled compared to levetiracetam and zonisamide. And when you looked into the detail of this studies of these responses, lamotrigine actually surpassed levetiracetam in terms of reducing seizures and in reducing side effects. And probably the most important point I think that came out of this study was the major reason that levetiracetam and zonisamide didn't do as well as lamotrigine was 30% of patients with both drugs discontinued treatment due to moodiness or psychiatric side effects. And so often we have to adjust medicines to optimize seizure control. And the only way to do that is to use the best tolerated treatments. And so adverse events, even though levetiracetam is widely used in the U.S., are very frequent with irritability and mood and depression problems. And so I think it's very important to consider this, and particularly when someone is getting treated and they're experiencing these side effects, to convert between medicines whenever possible to try to control their seizures. So here's a case example of this, trying to optimize treatment while minimizing drug side effects. This is a 62-year-old male retired executive. He became confused while biking 25 miles, and he had a left temporal glioma identified, and he developed clusters of focal seizures with impaired awareness. He was seizure-free and alert and cognitively intact on levetiracetam 750 milligrams twice a day, but his family reported really pretty unacceptable irritability and moodiness in him. He's a very kind of smooth, pleasant guy, and he was just very snappy and felt very depressed on levetiracetam. So he was switched to brivaracetam 75 milligrams twice a day, and he developed normal mood with no depression and no irritability. And so this is a typical example of how you can often use newer medicines to circle around and avoid drug side effects. So this is a graph showing a typical series of patients who had irritability or aggressive behavior on levetiracetam. And this shows how many were improved, unchanged, and worsened when they were switched overnight to brivaracetam. And so basically about 80% of patients, if they're having moodiness or irritability on levetiracetam, they can be converted to brivaracetam with marked improvement where they lose these symptoms. I think these types of changes that we can see in patients with drug conversion are very important to pay attention to. Too often, we ask patients to put up with drug side effects. We'll often not see that there's perhaps really adequate alternative therapies available for them to minimize side effects. And I think that's really highlighted in this graph showing the benefit of converting patients who are having mood problems on levetiracetam to brivaracetam. And so when we're initiating an anti-seizure medicine, particularly when they're on another product, another anti-seizure medicine, and perhaps they're still having seizures or they're having drug side effects, we really need to consider pharmacokinetic interactions between drugs if we're converting therapies or adding therapies. We need to consider pharmacodynamic interactions and the effects in general of polypharmacy on drug side effects, and just consider whether the polypharmacy is really necessary in so many of our patients. So pharmacokinetics is when there's drug-drug interactions with shifts in drug levels due to usually alterations in excretion or metabolism of the drug. Pharmacodynamics is combined drug side effects due to CNS effects of drugs. And with polypharmacy, they're developing a sedation or side effects from combined effects of drug, where the blood levels haven't changed, but it's 1 + 1 = 3 in terms of side effects. Often they're CNS related symptoms like sedation or imbalance. And in general, when there's polypharmacy, patients risk pharmacokinetic and pharmacodynamic interaction. It's more common at high doses where there can be more PK interactions and there can be more PD interactions. And so pharmacokinetic and pharmacodynamic interactions can cause loss of adherence because patients aren't tolerating drugs. And I think it raises the possibility that we often need to convert between drugs if patients aren't doing well on one drug and we want to try a different therapy. And so, one thing I think to consider when we look at that long list of new medications and options in adjusting treatments to match particular patient needs, one general theme I think you're going to see is that newer anti-seizure medicines, they often have better tolerability than older drugs. And the newer drugs often, there's less sedation, less grogginess, less imbalance, less uh, uh, PK interactions. But intolerable and adverse events can still occur with newer drugs, particularly if we're combining them with other drugs at high doses. And so it's very important to monitor for drug side effects when you're using polytherapy, and whenever possible, to try to convert between drugs. And they're particularly common when we're titrating a concomitant anti-seizure medicine. So I often have a formula where I give patients schedules and I gradually reduce one drug as I add a new drug and actually often convert them between drugs. And polypharmacy often includes high doses leading to increased toxicity, but it's very important to recognize polypharmacy can cause kind of a multiplicative effect on adverse events. So, for example, if you have topiramate added to another drug, the drug side effects double compared to topiramate monotherapy. And in general, you see this sort of multiplication effect of polypharmacy leading to increased toxicity. That's why I think it's very important to try to convert patients between therapy. They've often not tolerated or haven't responded to that other treatment. They're still having seizures. And you'd be surprised how helpful it is to switch between drugs whenever possible. And this can often be done proactively. So I often will give patients a schedule. I'll gradually take them down from a high dose of one drug that wasn't successful. I'll titrate up on a new drug. By doing that, they'll avoid side effects and tolerate the new therapy better. And this is particularly common when you're combining two sodium channel drugs. So, for example, in general, if you combine, say, lacosamide with a high dose of oxcarbazepine, they may not tolerate lacosamide, and you may need to titrate between these drugs. And it's a very straightforward thing to give patients schedules to cross titrate between drugs. And I commonly do this with lamotrigine, lacosamide, uh, oxcarbazepine, cenobamate. These are all sodium channel modulators where you're often better cross titrating between drugs when switching therapy. This is an example of doing this with cenobamate. So there was a large safety study done of 1,300 patients where we titrated slowly over 12 weeks to 200 milligram target doses. And when we looked back and we looked at epilepsy centers and looked at what was successful in terms of concomitant drug alterations or adjustments to maximize cenobamate, The first thing that seemed to help most patients is if there's a PK interaction, try to reduce those drugs rapidly as you're going up on cenobamate. So phenytoin, phenobarbital, and clobazam all have major PK interactions with cenobamate. So when I start a patient on cenobamate, I have their clobazam. I often have their phenytoin. Now, as you go along and titrate further, then you get into PD interactions with some concomitant drugs, and it's best to lower those. So if a patient's on a high lacosamide dose, lower that dose. If they're on 600, lower it to 400. If they're on 400, I'll often go to 300 a day. And so often as you're going through a sequence of adjustments and you're trying to optimize a new drug, try to reduce drugs that produce PK interactions. Try to reduce drugs from high doses to medium doses to avoid combined effects of drugs causing PD interactions where they're dizzy and drowsy. And then to the right, you'll see drugs that were adjusted fairly late in titration and cenobamate. And they were largely adjusted because they weren't necessary. Their seizures had gotten controlled on the new therapy, and you were able to lower levetiracetam or brivaracetam or other medications that don't have a lot of PK/PD interactions with the drug. And so historically, when a medication is added, patients report adverse events, the new medication is discontinued. And I think one good lesson that should come out of this program is that what you really want to do is leave behind the old unsuccessful therapy and convert to the new medication. And the best way to do that is to down titrate it as you optimize the new drug. So we reduce the medication that failed, not the new medication that's being added.
All right. That was a great case. And to circle back around to drug resistant, uh, the drug resistant population, I want to present one final case in a patient with drug resistance. And in this case, this gentleman was 43 years old. He had non-lesional drug-resistant focal epilepsy arising from the right frontal lobe. He had seizures since childhood and had failed numerous medications over the years. He actually underwent a right frontal resection and an RNS implantation in 2016, which was fairly effective in reducing his seizures, but he did continue to have seizures, um, clinical seizures that he was very aware of, bilateral tonic-clonic convulsions every 1 to 2 years. But of course, his RNS additionally detected seizures that weren't tonic-clonic, that were more subtle, occurring in his sleep. And those were continuing despite 4 anti-seizure medications: lamotrigine 200 twice a day, zonisamide 500 at night, clonazepam half a milligram at night, and oxcarbazepine 600 at night. And then it was about at that point in time that he established care with me. And I actually used his ECOG data, which is electrocorticography recorded on his RNS device, to help with medication management and adjustment and seizure tracking. Because, like I said, he was not always aware of all of the seizures he was having. And so this is a typical graph that we can see when we're reviewing RNS uh, during programming visits. And on the x-axis, you have time, and this is just selecting for his long episodes, which correlated well with his seizures, both clinical and subtle. Um, and so in around July 2022, I decided to start a new medication, in this case, cenobamate. And you can see that going from left to right, his ECOG detected long episodes drop off as I'm going up on the cenobamate. And I'm watching this over time, and I start peeling off his other medications. And as of January of 2025, he remains seizure free. not just clinical seizures, but also all of his RNS detected uh, long episodes and without any side effects on cenobamate monotherapy. So something he never thought would be possible would be just being on one medication again, and we achieved that despite the fact that he was very drug resistant. And so this was a paper that was published in 2022 looking at the efficacy of cenobamate for people with focal seizures who had undergone previous epilepsy surgery. And this chart shows comparison groups of people who underwent surgery and people who didn't, and were drug resistant, and shows that there wasn't a significant difference between these two groups in terms of seizure freedom when starting cenobamate. Kind of highlights the fact that even in people who have drug-resistant epilepsy, starting a new med can lead to seizure freedom. And then the other thing to highlight from this case is evaluating ECOG responses on RNS. So people who do undergo surgery and have an RNS, that device can give you a lot of valuable data in terms of tracking over time, and has been a nice marker for how well people respond to anti-seizure medications. This trial, published in 2024, looked at people who were started on clobazam, lacosamide, levetiracetam, and pregabalin, uh, and who had RNS. And across the medications, there was a good data to show that ECOG data could show a response to them. In this study, they found that clobazam and levetiracetam had the best responses compared to lacosamide and pregabalin. I think it really highlights the fact that ECOG from RNS is a valuable tool to assessing medication responses.
Thank you both so much for your excellent cases. In conclusion, we just want to highlight that it's important to optimize therapy to improve seizure control and to do it early on in the course of the disease, because we know that epilepsy is a progressive disease. And we know that the longer we wait, the more impact it can have on their social relationships, their ability to work, their ability to get education, their ability to drive. Again, as Dr. Paladin just said so eloquently, not stopping the workup, but giving them something while they are getting worked up or in that process that may make them seizure free sooner. It's very important to look at all of the drugs that they're on, look at their quality of life, look at their comorbidities. It was eloquently shown with Dr. Krause's case, side effects that were disrupting his everyday functioning and mood and ability to interact with his family. And so it's important to look at the comorbidities, look at the side effects, and change the drugs accordingly, as our goal is the best quality of life. This also includes thinking about the drug load and reducing medications that may not have helped in the past. Again, no longer are we doing the last one on, first one off, because the last one on is often a drug that potentially may provide better efficacy. And if the other medications weren't working, we should take those down either concomitantly or once we've achieved seizure freedom, so that we can get them down to not only the increase in the other medication, but also in their side effects, their comorbidities, their drug load, their cognition. Also, we've talked about the fact that there are medications that continue to come out. And so, even if someone has had surgery, has had neuromodulation, never stop thinking about other newer options that may come along, especially if they have not achieved seizure freedom or seizure control. And lastly, just to really take it home, this is a journey. We want to try to provide options as soon as possible to get the patients seizure freedom as fast as they can and or the best quality of life. And with that, I want to thank Dr. Krause and Dr. Pellinen for a lively discussion and important take-home messages today.